Good afternoon, sir. Dr. Ramesh, sir, I hope you can hear me.
Yes, Rupali, I am here.
Good afternoon, sir.
Yeah, good afternoon.
Good afternoon, Dr. Ramesh, Dr. Upali.
Yeah, good afternoon, sir.
But none of you is visible. What is the problem? Nah, Dr. Ramesh is visible now. ये जो Dr. Upali, you can share your slides once so that you don't face any problem.
हाँ जी,
Good afternoon,
yes.
Dr. Upali. Yes, thank you.
सर मैं शेयर कर रही हूँ. Is it fine, sir?
Yes, fine. Just change the slides once so that we know it is moving.
ठीक है सर. Hmm. It's not moving.
Not moving?
Not moving, sir.
What I will suggest that you can log out once and try to log in again.
ठीक है.
Because that is what is the usual process.
हाँ, ठीक है
That
sir.
I know of. Sorry.
Okay, sir. I will just do that.
Please put it on slideshow view, Dr. Rupali.
Now it's moving, sir, I think.
Yes, we can see it. Can you just change the slides?
हाँ जी, sir.
Yes, now it is moving. Yes, perfect.
Okay, sir. Thank
So
you.
we wait for a couple of minutes, Dr. Rupali, then we will start.
Fine, sir. Fine.
A very good afternoon. Shall we start, Dr. Rupali?
Yes, sir, absolutely.
Well, thank you. A very good afternoon to everybody and welcome back to this ICP API online certificate course. And in this series, now we are moving ahead and today's topic is cardiac tamponade, which is a very important topic. And for this, we have a very enlightened and senior Professor Dr. Rupali Malik from Bardhaman Mahavir Medical College, Sarojang Hospital. He's professor in medicine, fellow, and special interest in a number of other diseases. Also, she's looking after the HIV clinic there. And I will request her to take the today's session forward. Dr. Rupali, please.
A very good afternoon, everyone. So I welcome you all to today's session of Clinical Medicine Online Certificate Program by API ICP. And at the outset, I'm extremely thankful to Dr. Anupam Prakash, sir, for giving me this opportunity. And I will be discussing with you all the diagnosis and management of a very life-threatening condition that is cardiac tamponade. I hope I'm audible to all. Okay. So the outline of my talk will have some basics of pericardium, how to define cardiac tamponade, its etiology, pathophysiology, the clinical features and diagnosis of cardiac tamponade, and lastly, the management of cardiac tamponade. Now, when we talk of pericardium, we all know that it is a double layer structure consisting of the visceral and the parietal pericardium, and together they form the pericardial sac, which contains the pericardial fluid. And the main function of this pericardial sac is to prevent sudden expansion of heart chambers during increased cardiac activity. So this is the main function. They restrain the cardiac chambers or they prevent sudden expansion of the heart chambers. And also they will also prevent the spread of infection from the surrounding structures like the lung, the pleural cavities, etc. Normally, we have an amount of around 15 to 50 ml of fluid in this pericardial sac, and the pressure is around -2 to -5 centimeters of water, and it varies with respiratory cycle. Now, when we talk of this visceral and the parietal layer of pericardium, the visceral layer is a monolayer of mesothelial cells, along with some collagen, elastic fibers, and it is adherent to the epicardial surface of the heart, whereas the parietal epithelium is a acellular structure. Please, it is acellular. It is a fibrous structure made up of collagen and elastin. Now, this parietal pericardium is stretchable, but at a low stretch, it is very elastic, while when we stretch it further, it becomes very stiff. Okay, so now this is something very important for us to understand. And this is what is being reflected in this pericardial pressure volume curve. So this is what is being reflected. The pressure volume curve of pericardial sac reflects the property of this tissue. That is, the curve is very flat, a compliant segment in the initial parts, but abruptly it will transition to a non-compliant segment around the upper limits of the cardiac volume. So this is something very important. So at the lower volumes, it is very elastic at lower stretch, but when we stretch it further, it will become stiff. And this is what is the basic of the pathophysiology of cardiac tamponade. To begin with, it is very stretchable or elastic structure, but later on, it will become very stiff. So because of this property, now what happens is, as the pericardial effusion initially increases, the pericardial sac can accommodate the expanding volume of fluid without significant increase in pressure or compromise of the cardiac chambers. But once the pericardial reserve volume is reached, there would be a sudden increase in the pressure. So this is something important for all of us to understand. So when this critical volume of fluid is achieved, there would be a sudden increase in the pressure. So when you have a rapidly rising pericardial fluid level, it will lead to a steep rise in pressure. This is something important. So once the pericardial reserve volume limit is reached, even a small amount of addition of fluid can lead to steep rise in the pressures. And the curve becomes steeper even with small increments of fluid. So this one important message I wish to give right from the beginning of the lecture. But when you have a slow filling of the fluid, then the pericardium have enough time to stretch and accommodate and have compensatory mechanisms. And then you can accommodate comparatively larger amounts of fluid up to 1.5 to 2 liters before the hemodynamic compromise will start. So this is important. In acute situations, even 200 amount of fluid will lead to sudden rise of pressure. But in the chronic situations, even 1.5 to 2 liters of fluid can accumulate without any hemodynamic compromise. Okay. Now moving on to cardiac tamponade. So what is cardiac tamponade? It is a pericardial syndrome characterized by accumulation of fluid most of the times, but it can also be pus, blood, clots, or gas, okay, in the pericardial space, leading to impairment of the diastolic filling of ventricles and a low cardiac output. So this is what is cardiac tamponade. Because of the filling of pericardial sac with either fluid or blood or pus, whatever it is, it would lead to impairment of the diastolic filling of the ventricles, which would ultimately lead to low cardiac output. Okay. So in other words, we can say it is a serious and a potentially life-threatening situation arising from compression of heart due to pericardial fluid caused by either accumulation of fluid, which can be because of effusion, trauma, or heart rupture, whatever it is. Now, most of the times in developing country like ours, the most common cause in clinical practice for cardiac tamponade is pericardial effusion related to tuberculosis. Other causes which are more often seen in the developed worlds are those related to trauma, though we can have it here also. But in developed countries, trauma and secondary to cardiac intervention are the most important causes of cardiac tamponade, while in our country, it is the infections like tuberculosis and the effusion associated with them, which are the most common causes. Okay, so when we talk of causes of cardiac tamponade, it could be following cardiac procedures like radiofrequency frequency ablation, pacemaker implantation, and other cardiac interventions. Other causes could include malignancy, infections like tuberculosis or others, and inflammatory conditions also. So in connective tissue or collagen vascular disorders, also you can have pericardial effusion sometimes. Sometimes it could be big enough to cause a tamponade. Then post-myocardial infarction, there could be a free wall rupture. Aortic dissection can also lead to this complication. Then systemic inflammatory diseases, I've already mentioned. And also patients with uremic pericarditis, the renal failure patients can also have this complication. So what happens in these conditions is, as I've just mentioned, that there is compression of all the cardiac chambers due to the rise in the intrapericardial pressure. So rising intrapericardial pressure would lead to compression of the cardiac chambers. Initially, the pericardial fluid expands to the limit of pericardial reserve volume, which I just mentioned earlier. But once the expansion rate increases, it surpasses the ability of the pericardium to stretch further, causing the heart to compete with the increased pericardial contents for the limited intrapericardial volume. And this would ultimately lead to a reduction in the size of the chambers and a myocardial diastolic compliance limitation. So this is something important. And what will happen is ultimately there would be equalization of mean diastolic, pericardial, and the chamber pressures. So the heart literally becomes fixed. The volume of the heart becomes fixed. The pressures, they become fixed, okay? So further increase in the volume would lead to increase in the pressure after the critical pericardial reserve volume is achieved. And the first chamber to be affected is the right side of the heart, followed by the other chambers, okay? And as the cardiac volumes progressively decline, the stroke volume will be decreased, and because of the decrease in the end diastolic ventricular volumes. That is, the preload is basically the one which is decreased first. Now, so pericardial fluid, when present in excess of the upper limit of 50 ml, it is known as pericardial effusion. And when this pericardial effusion is sufficient enough to cause significant pressure on the heart chambers, causing hemodynamic instability, this is what is known as pericardial tamponade. And as we have discussed earlier, in acute cases, even as small as amount of 200 ml can cause tamponade, but in chronic cases where there is a significant compensatory mechanism setting in and there is a significant time which is there, you can have up to 2 liters of fluid accumulating before there is hemodynamic compromise and cardiac tamponade. Now, when should we suspect this condition? This is very important because only when we suspect, we will be able to diagnose. So in general, the pericardial diseases, they present with a chief complaint of chest pain. And this chest pain is usually pleuritic in nature. It is a sharp stabbing pain, usually felt in the middle of the chest or the left side of the chest, and it increases on inspiration, coughing, lying down, and would improve upon sitting or leaning forward. So these are all characteristic features that you can have in pleuritic pain, and similarly you have in pericardial pain as well. And sometimes the pain can also radiate to neck, jaw, shoulders, and arm, confusing us with a diagnosis of acute MI at times. Okay. And this pain can be persistent if there is underlying myocardial ischemia. So sometimes ischemia can be there along with tamponade in these patients. But in, in patients of chronic pericarditis, the pain may be absent. Now, other than chest pain, other features can include chest heaviness, fatigue, palpitations, dyspnea on exertion, abdominal distension, feet and extremity swelling. So these are all signs of right heart failure. So shortness of breath is something important. So chest pain and shortness of breath are the two cardinal symptoms, and especially dyspnea on lying down. But we all understand that if the patient is unconscious or obtunded, then these features may not be very obvious. Sometimes patient can have just vague symptoms like anorexia, dysphagia, cough. Okay, so most of these symptoms are really non-specific. So strong suspicion in high-risk situations is what is required. Okay, since most of these signs are non-specific, you have to have a very high and strong index of suspicion. And when should we suspect this? So any patient presenting with hypotension, along with symptoms of an underlying pericardial disease like chest discomfort, pleuritic chest pain, or some history of chest trauma or the abdominal trauma. So in all these situations, if the patient has shock or hypotension, you must strongly consider the diagnosis of tamponade also, or differential diagnosis of tamponade. Okay. Now, when you examine these patients, you always have to look for stigmata of all chronic illnesses, malignancy, head-to-toe examination for connective tissue disorders, thyroid disorders should also be looked for. Now, when we talk of these specific signs of cardiac tamponade and the pericardial involvement, you have to look for JVP, the blood pressure, the pulse volume, and the pulsus paradoxus. Now, I will go in details of all of these things. Now, the cardinal feature of cardiac tamponade is defined by this Beck's triad. In Beck's triad, we have three components: distended neck veins with elevated JVP. Then you have reduced heart sounds. So this is what is the cardinal feature of tamponade. Okay, and along with that, you can have in patients with large effusions, you can have a bronchial compression leading to tubular type of bronchial breathing in the left axilla or the base of the lung. So this is again one important sign in patients of cardiac tamponade. The acute cardiac tamponade usually will present with low blood pressure, but sometimes in subacute to chronic cases, the blood pressure may not be that low. And also in patients who have pre-existing hypertension, they may also have normal to even slightly elevated blood pressures sometimes. Okay. So in cases of rapidly developing tamponade, patient often displays signs of shock such as cool extremities, nose, ears, and occasionally peripheral signs. So shock would be more evident in rapidly developing tamponades. In other situations, sometimes they can even have a normal or not that decrease of blood pressure may be appreciated. Now, on examination, JVP, as I mentioned, is usually elevated with characteristic loss of the Y descent with a normal X descent or prominence of X descent. Now, this features differentiates tamponade from constrictive pericarditis. So loss of Y descent, which is a characteristic feature of tamponade, is not seen in constrictive pericarditis, which is an important differential, where rather there is increased prominence of Y descent. So this is an important feature which differentiates tamponade and constrictive pericarditis, the loss of Y descent. Both conditions will have raised JVP. The X descent can be prominent, but loss of Y descent in tamponade is characteristic. Then signs of peripheral venous distension can also be seen. And other places like forehead, scalp, fundus can also have prominence of venous pulsations. Heart sounds are muffled, again a characteristic feature of tamponade, a part of the Beck's triad. Now, most of these patients would generally have a quiet precordium, but still the apical beat can be palpate. Okay, so it looks quiet, but when you palpate, the apical beat can be appreciated. And tachycardia is classically present except in patients who have uremia, hypothyroidism, or those who are already on some for some reason on beta blockers or have some coexisting conduction system disease or are experiencing pre-terminal bradycardia, bradycardic reflex. So other than that, tachycardia is the usual feature that we see in these patients. And in pericarditis related effusions, pericardial rub is also audible. Now, next characteristic feature that we see in these patients is pulsus paradoxus, which is an inspiratory drop of more than 10 millimeters of systolic blood pressure. Now, this is just an exaggeration of normal phenomena, which we all know. Now, in patients with cardiac tamponade, this phenomena is seen because of exaggerated ventricular interdependence in cardiac tamponade. Okay, so because the total cardiac volume and the chamber's volume becomes fixed. So if one chamber enlarges, the other will have to decrease in volume. So when there is inspiration, the volume of blood in the right side of the heart, the right ventricle will increase. So, but this will happen only at the expense of the left ventricle chamber. So if the volume of right side is increasing, the volume of left side has to decrease. This is what is exaggerated ventricular interdependence. And if the left-sided volume decreases, that would decrease in the cardiac output and decrease in the systolic BP. So this is what is the basis behind the pulsus paradoxus that we see in these patients. Now, but this is not something specific to tamponade. Pulsus paradoxus can also be seen in patients who have massive pulmonary embolism, severe hemorrhagic shock, or other forms of severe hypotension and obstructive lung diseases. Sometimes tamponade can also happen without pulsus paradoxus, and this is seen in patients who have pre-existing elevated diastolic pressures or volumes, such as chronic left ventricular dysfunction, aortic regurgitation, or atrial septal defect. So people who have increased left-sided volumes already, so they might not experience pulsus paradoxus sometime in this situation. Now, this is just a pictorial representation of the various waves of JVP, which you all know. And what are they representing? So we have 3 positive waves in JVP, A, C, and V, and 2 negative waves, that is X and the Y descent. So A is actually corresponding to the atrial contraction. C is to the bulging of tricuspid valve into the right atrium during ventricular contraction. V wave is increase in volume of the blood of right atrium during ventricular systole and the volumetric relaxation phase of tricuspid as the tricuspid valve is closed. Now, X descent is the negative systolic wave because of atrial relaxation and downward displacement of tricuspid valve during ventricular systole. And Y descent is opening of the tricuspid valve and rapid inflow of blood into the right ventricle. Now, what is characteristic of cardiac tamponade is loss of Y descent. And why is there a loss of Y descent? Because of the fixed volume, the inflow of the blood into the right ventricle is not happening. That is why the loss of Y descent is there in patients with cardiac tamponade. Now, this is a video showing the various waves of the JVP. I hope you can all appreciate. So this is a pictorial representation happening here. So the negative waves are better appreciated compared to the positive waves, and usually the X descent is what is most often and best appreciated in the JVP waveforms. Okay, so JVP is raised. So JVP is raised not only in pericardial tamponade, but other pericardial diseases also like effusion, constrictive pericarditis, etc. But not only that, even in non-pericardial diseases, JVP can be raised like cor pulmonale, PAH, pulmonary valve stenosis, right ventricle MI, tricuspid stenosis, CHF, fluid overload, etc. This we all know. So this X descent I just mentioned is the most prominent motion of normal JVP. It begins during the systole and ends just before the S2. And it is because of the atrial relaxation during atrial diastole. It is usually larger than the Y descent and is more prominent during inspiration. And this X descent becomes even more prominent in patients with pericardial tamponade, constrictive pericarditis, restrictive cardiomyopathy, and right ventricular infarctions. And it will be absent, obviously, in patients with tricuspid regurgitation. Now, Y descent. Now, this is a feature which differentiates constrictive pericarditis and tamponade, as I have been repeatedly telling. So, the Y descent becomes more prominent in constrictive pericarditis, restrictive pericarditis, RV infarction, while it is absent in conditions of cardiac tamponade or the effusive type of constrictive pericarditis. Not all patients of constrictive pericarditis will have effusion, but if there is effusion, then it might be absent. But otherwise, in constrictive pericarditis, there is prominence of the Y descent. Pulsus paradoxus also I've already mentioned. Now, small signs is seen in patients of constrictive pericarditis and not cardiac tamponade. So, just to finish of the list of signs when we talk of pericardial disease. So, this is one sign. So, this is defined by raise in the JVP during inspiration, and it is a characteristic feature of constrictive pericarditis and not seen in tamponade. This is one feature which differentiates them.
Descends characterized by the rise in tricuspid pressure inspiration.
So this is just
rise of pressure inspiration.
showing how on abdominal pressure there is a rise in the JVP. Okay, now pericardial rub is also audible in patients. This is usually audible in acute situations, acute tamponade with acute pericarditis. This pericardial knock, Broadwind sign, they're all signs of constrictive pericarditis, not seen in patients of tamponade. Even Evart sign, which I mentioned earlier, also is a sign of large pericardial effusion. It is dullness, egophony, bronchial breath sound at the inferior angle of the left scapula, sometimes even at the in the apex of the axilla, you can hear this. Okay, now moving on to diagnosis of cardiac tamponade, the diagnosis is primarily clinical. So if a patient is suspected to have hypotension, raised JVPs there, muffled heart sounds are there. So in the right clinical context, you have to suspect the disease. There's a history of chest trauma or there is a history of abdominal trauma. So in these situations, you have to suspect this condition. And when you do the ECG, they will typically have tachycardia with a low voltage QRS. But this is all non-specific. Sometimes in acute pericarditis patients, the signs of pericarditis like the diffuse ST elevations may be seen in some patients. Now, what is specific to tamponade is the electrical alternance. Now, this is a specific sign, but relatively insensitive. So most of the times patients will not be having, and this this may not be seen, and this is seen secondary to swinging of the heart. I will just show you the pictures of the same. Yeah, so this is an ECG showing electrical alternance. So you have large and small voltage complexes alternatingly. Okay, so low voltage complex with electrical alternance. Okay. So other than ECG, you have to do a chest X-ray where you can have a cardiac silhouette sign, and the silhouette would be resembling a flask. If there's a large effusion, the cardiac silhouette might be resembling a flask, but this may not be seen in acute situations. 2D echocardiography is usually used to confirm the diagnosis of tamponade. Cardiac catheterization can reveal equalization of the mean diastolic pressures, but is usually not done. CT and MRI also not generally required unless the Doppler echo is not feasible. So 2D echo is what is used to confirm the diagnosis of tamponade, how we will just discuss. So ECG we can have, these are the changes of acute pericarditis. This is electrical alternance and the low voltage complexes. Now in X-ray we have some signs. So cardiac slit sign, you can have enlarging cardiothoracic ratio. There's cardiomegaly. There's widening of the subcarinal angle without other evidence of left atrial enlargement. So this also might be an indirect clue. And the shape of the cardiac shadow looks like a money bag. Now, on the lateral radiographs of the chest, there's a Oreo cookie sign which can be seen in patients with pericardial effusion. Now, what is this Oreo cookie sign? This is actually the pericardial fluid is seen as a vertical opaque line separated by the translucent lines in front and behind, which is the pericardial fat and the epicardial fat. So we have pericardial fat and epicardial fat, which are black, and in between there is an opaque line of the pericardial fluid. So this is on the X-ray, lateral X-ray of the chest that we can see. Oreo cookie sign. Now, what is confirmatory of the diagnosis of tamponade is usually the findings that we have in the cardiac echocardiography. Now, in echocardiography, you can have the pericardial effusion, then you can have the atrial collapse and the right ventricular collapse during the diastole. So diastolic right ventricular collapse. So this is what is characteristic feature of tamponade. Another feature is, so in tamponade, there is a late diastolic inward motion collapse of the right ventricular free wall and the right atrium. So this is what is characteristic feature. Other features that you can see are IVC plethora, the exaggerated respiratory cycle changes in the mitral as well as tricuspid inflow velocity. I will just show you that. So this ventricular collapse, if you can, I'm not sure if it is appreciable. So in this
indicated by the blue arrows there and there. Now the sensitivities and the specificities.
Okay, so this is the atrial collapse, which is being demonstrated in this video. I'm again showing, so right atrial collapse.
As indicated by the blue arrows there and there. Now the sensitivities and the specificities.
Remember back in high school calculus, we talked about concavity of lines. And when it's
Here it is the
downward, then it's
RV collapse, which is being shown in the
Fritz Fox, I've heard him describe this as
next video. Now, this is what is showing the plethoric IVC. Now, plethoric IVC is what? IVC plethora is lack of normal inspiratory collapse of a dilated IVC on echocardiography. So, normal individuals during inspiration, there would be a collapse of the IVC diameter. So, normally IVC diameter decreases by about 50% during inspiration. But this is not seen in patients with right heart failure or cardiac tamponade or constrictive pericarditis. So, IVC plethora.
this is an ultrasound of the
So this is the video showing the IVC plethora.
Just to the right of the midline.
And lastly, normally there is some minor respiratory variation in the flow velocity of the mitral valve, but this normal respiratory variation is exaggerated in tamponade. So this is what is being shown here. So there's a drop of more than 25% in the mitral valve inflow velocity in tamponade
In and
patients.
out of the
So
heart
this is
varies with respiration.
more than
In
25%.
tamponade physiology, the variation is exaggerated.
Okay, so normally there's a minor drop, but here there is a drop of greater than 25% of the mitral valve inflow velocity in patients with tamponade.
In and out of the heart varies with respiration. In tamponade physiology, the variation is exaggerated.
Okay, so important differentials of tamponade are constrictive pericarditis, restrictive cardiomyopathy, RVMI, effusive type of constrictive pericarditis. So I will not confuse you with much, but important thing is how to differentiate tamponade and constrictive pericarditis. So one thing was in the jugular veins where prominent X descent is a feature of constrictive pericarditis, but not seen in patients with tamponade. So there's an absence or loss of wide descent in tamponade. This is one important feature. Then electrical alternance is a feature of tamponade, not constrictive pericarditis. Low voltage ECGs are seen in both of them. Now, the pericardial knock is a feature of constrictive pericarditis not seen in patients of tamponade. Pulsus paradoxus can be seen in both, but much more often seen in patients of tamponade. Then pericardial effusion is seen in tamponade, but not in patients of pericarditis. Okay, and the RV size is usually small in patients of tamponade, but in constrictive pericarditis, it may be normal. Now, lastly, we move on to the management of this life-threatening situation. Now, the goal of the management is to support the compensatory mechanisms like these patients will already be having a increase of the inotropic hormones. Okay, so we don't have to give them inotropes left, right, and center. We have to keep in mind that already they will be having enough endogenous inotropic stimulation would already be maximized in these patients. So we have to be very careful before we give inotropes like dobutamine, though sometimes they are given, but there's only a theoretical benefit. Otherwise, clinically, the benefit may not be appreciable because of already enhanced inotropic stimulation. Now, when we talk of fluid administration, again, we should be very cautious. Fluid should be given only in patients who are obviously hypovolemic. Otherwise, the additional fluid can raise the intracardiac pressures and the heart size, and thereby increasing the pericardial pressures and worsening or negating the low transmural myocardial pressures that support circulation. So this is important. So unnecessarily, we don't have to give them too much of fluids. Okay, so not too much of inotropes, not too much of fluids, be very careful. And also, positive pressure mechanical ventilation should be avoided as it can further diminish the cardiac output. So this is important. We should always remember what we should not do. So left, right, and center, do not give them fluids or inotropes when we see shock. Be very judicious. Fluids only when there's hypovolemia. Dobutamine is plus minus. You may give it a trial. If it benefits, okay. But otherwise, in most patients, there may not be any additional benefit with these inotropes. Now, what is the definitive treatment of cardiac tamponade is to drain the pericardial fluid, or that's to do a needle pericardiocentesis guided by echo or a fluoroscope. Now, in the beginning itself, I told you that because of that pressure volume curve, okay, because of the pressure volume curve, the shape of the curve dictates that when the critical volumes are achieved, the small addition of fluid will lead to large increase of the pressures. Similarly, even small removal of fluid will lead to striking benefit. So very important. Even little fluid, if removed, will give striking benefit to the patient. So pericardiocentesis is very important. Okay. So usually a subxiphoid approach is what is used. A closed pericardiocentesis is usually what is done. Now, in patients who have recurrence, pericardiectomy may be required, and sometimes the intrapericardial instillation of sclerosing agents would also be required in patients who have recurrent effusions, especially in the neoplastic patients, in the patients who have underlying cancers. So subxiphoid approach is what is used for pericardiotomy. Open pericardiocentesis is advisable in patients with hemopericardia. Now, this is again something very important. Normally, we do a closed pericardiotomy, but in patients with pericardium secondary to trauma, aortic dissection, or pericardial effusion, or free wall rupture after the MI, you should do a open pericardiocentesis, because otherwise, if there's ongoing bleeding, you may not be able to stop it. So the open pericardiocentesis will give the opportunity to stop the bleeding if required. So in those situations, it is preferred to do an open one. Otherwise, you do a closed pericardiocentesis. Now, one important complications which can happen after sudden and the rapid large removal of fluid is the cardiac decompression syndrome. Okay, so cardiac decompression syndrome can sometimes be a fatal complication associated with the rapid and the sudden removal of the pericardial fluid. Okay, so normally there's no pulmonary edema in patients of tamponade. For some unknown reasons, pulmonary edema is not a feature of cardiac tamponade. But in these patients with cardiac decompression syndrome, when you suddenly remove the fluid, There's a paradoxical hemodynamic deterioration, ventricular dysfunction, and that can be associated with pulmonary edema. So be very careful when you remove sudden and the large amounts of fluids. And the outcome of these patients would depend on the underlying cause, final outcome. If it is neoplastic or metastatic disease of the pericardium, the outcome would be poor. But in other conditions, the long-term outcome is comparatively better. So that would be all, I think. So this is the last slide that I have. So cardiac tamponade is a critical emergency that necessitates a high level of clinical awareness for early identification and treatment. Timely clinical assessment combined with ECG, a 2D echocardiography is crucial for confirming the diagnosis, and performing pericardiocentesis under guidance of the echocardiography or fluoroscopy is safe and a potentially life-saving procedure. So that will be all.
Thank you, Dr. Rupali. I think there are some queries in the chat box.
Okay, sir. Let me just see.
Why backstride not present in all cases of tamponade? In which clinical scenario low pressure cardiac tamponade develops?
Low pressure cardiac tamponade is usually seen in patients who are hypovolemic. So even sometimes we can have hypertensive cardiac tamponade. So both can be there, but overall the prognosis is poorer when it is in a low volume setting, low output setting, compared to when the blood pressure is not that low.
And at times, all the triad is invariably the characteristic is all the three features should be present, but it is not always there. So you can have some variation which happens in most diseases. So you have classical triads in a number of diseases, but it is not always that you get the triad. So any other queries you can just post in the chat box.
I think, sir, Dr. Rupali has very simplified the topic, although it was very complex. If I remember the undergraduate and the postgraduate, they always struggle to remember and understand how the Y descent and the X descent move in the four common differential diagnoses of constrictive pericarditis or cardiac tamponade, or restrictive, or the RVMI. So very beautifully she has explained. We must compliment her for doing this.
Definitely,
Thank you,
she
sir.
deserves a
Thank
good
you
round
so
of
much.
applause.
I hardly knew anything about the topic before
And
sir
that
asked
is the
me
art.
to
Even when
take
you
it.
don't know, you study and you then tell everybody and make the topic very simple. That is the class of a senior professor. Well, thank you, Dr. Rupali. If we have any more queries, we can take. Otherwise, we will close down the session. So, no more queries, I think. So, thank you so much, Dr. Rupali. A wonderful
Thank you
job
so
done.
much, sir. Thank you.
And we look forward to the next session next
All
week
thanks to
again.
you, sir.
And thank you, then. Thank you so much. Thank you, Dr. Ramesh, and thank you, Dr. Rupali, also for joining. And all these participants also. I see a good attendance, and I'm sure that everybody must have learned some tricks of the trade of clinical medicine. Well, thank you so much.
Thank you.